that is on post oscillometry technique and impulse oscillometry in asthma. After the sessions of diagnosing asthma in less than 5 years and diagnosing asthma in beyond 5 years, so this is the session that was long asked for, awaited. It will be taken up by our national chair, IAP NRC, Dr. N.K. Kalapanwar sir. So for this session, we are having two extremely esteemed delegates, guests. Our immediate past president, Dr. B.S. Sharma sir, who is now the course director of Advanced Asthma course. Welcome, sir. And to have her expertise on this session, we are having Dr. Rashmi Kapoor, ma'am, from Kanpur. To have a brief introduction of our speaker and expert. Dr. N.K. Kalapanwar sir, he was former medical director, now professor and head, consultant pediatric pulmonologist, Department of Pediatrics in SS Institute of Medical Science and Research Center, Devangiri, Karnataka. He was previous General Secretary IAP Karnataka, President IAP Karnataka, and President IAP Karnataka Respiratory Chapter 2. He has organized many state and national conferences, including Respicon. He was previous national EB member from Karnataka. Now he is the present president of IAP NRC for 2024. Has many publications in national and international journals to his credit and contributed many chapters in different textbooks. So welcome, sir, for this session on FOT and iOS. Thank you so much. Then thanks. Our expert today, Dr. Rashmi Kapoor, ma'am. She is from Kanpur. She has affiliation as Head Department of Pediatrics, Director Division of Pediatric Pulmonology and Critical Care, Regency Hospital, Kanpur, UP. She has areas of interest in pediatric pulmonology, bronchoscopy, and critical care, and extremely popular and very, very good speaker in respirology and pediatrics. She has 26 papers in national and international journals and has contributed chapters in 3 textbooks. Welcome, ma'am. Thank you so much for accepting our request. And we also welcome our immediate past president and present course director, Advanced Asthma course, Dr. B.S. Sharma sir from Jaipur, Rajasthan. Thank you, sir. Over to you, Dr. Kalapanwar sir.
Thank you, Dr. Modi, respected Dr. Rashmi Madam, Dr. B.S. Sharma sir, and all my dear delegates. At the outset, I thank the IAP NRC for this wonderful opportunity to share few things about, one of the most important, I think, probably need of the hour, and it is going to be the future of our all airway diseases and parenchymal diseases parameters. So with these notes, I'll share my screen. Sir, can you see?
Yes, we all can see.
Thank you. So the topic today is post.
Make it the slideshow.
I think it is.
No. You just click this.
Is it?
Yeah. Now it's
fine.
okay. Yes.
Thank you, ma'am. Let's move on to the very important topic is forced oscillation technique and impulse oscillometry in respiratory medicine. Today, I'm going to talk to you about entire talk will have a brief introduction and definitions, some important physiological concepts and terminologies, and graphs and interpretations of these graphs, and how to perform the test, and few cases, the case-based discussion wherein the FOT or IOS has helped to diagnose. And then finally, the conclusion remarks. To begin with, we all know the pulmonary function tests assist in diagnosis, help in follow-up, and also help in monitoring the therapy in many respiratory diseases. Among them, very commonly used one is spirometry. Every one of us know this. It is a well-established protocol, and many of us, we are very well versed with this equipment, and we are very familiar in interpretation also. But the challenge with this spirometry, it is difficult to perform, and it's a experience of all pulmonologists, especially pediatric pulmonologists. Nearly 70% of the patients are unable to perform a good quality spirometry, and thereby we fail to interpret them. And there are several contraindications for this spirometry. And also, very important thing we all need to know is this spirometry is effort dependent, and it requires a forceful maneuver. And simultaneously, it has got a limitations in assessing this small airway obstruction. So these are the few of the limitations with spirometry. So if you compare this spirometry, it needs cooperation from the patient end. It is effort dependent. Always it is a forceful maneuver, and very good training is required to train the patient, and less than 6 years and old age, because of the low understanding, it will have a lot of limitations and very, very low clinical correlation. And it's, as I said, has got a limitation in assessing small airway obstruction. Wherein if your FOT, very sensitive compared to spirometry, it assesses the small airway very well, and it requires normal tidal breathing. I will tell you again and again, these are the two important comparative measures with spirometry and oscillation. There, the spirometry is a forceful, effortful maneuver, whereas in case of FOT, it is a normal tidal breathing. So we all can do this test just above 3 years of age, and very good information about the what spirometry does not give. And as I mentioned, it is the future of lung function test in the near future of pulmonology. So let us see then what is the definition of these two. Are they two different, and how we should know them? FOT is a method to characterize mechanical properties of the respiratory system over a wide range of frequencies. So the IOS is, it is one of the variant of forced oscillation technique. Though it was described long ago, very important thing about this IOS is, it is a passive measurement of lung mechanics. So there is no active involvement or forceful maneuver required by the patient in these two techniques. So these are the definitions of FOT and IOS. Let us see, I will show you very important thing. We all are familiar with our physiology. This is how the tidal breathing, we will have a inspiratory reserve volume, and the expiratory reserve volume, and the residual volume. What are the equipments which give information about these measurements? If you consider the lung oscillometry gives you the tidal volume, and the spirometry will also give you a forceful or effortful, both your inspiratory and expiratory. And if you want a total lung capacity, one has to subject the child for body plethysmography. So you need a different equipments to assess and perform during these phases of respiration. So the oscillometry is done only during tidal breathing. The spirometry requires a forceful maneuver, and to calculate total lung capacity, one has to do body plethysmography. Okay, let's move on to the oscillometry test, how it is done. See, look, this measurement resistant at a different parts of lung at a different phases of breath cycle using pressure and flow measurement with the sound waves in a tidal breathing. So finally, what it sounds like, basically it is ultrasonogram of lung. So how it works? It is, to begin, I would say, just concentrate few of the things. At one go, it is difficult, but still you all can, understand this. Look at here. See, this is the tidal breathing, and you have two types of sound wave production equipments. One is a speaker, and another one is a piston. So the piston will produce sound waves with a certain frequency, or you can use a, sound mic. This is what is called as, I would say, speaker. So this speaker will produce. So in either FOT or IOS, you have these two source of sound waves production. Once this sound wave is produced, this sound wave is synchronized with the tidal breathing. Okay. And this tidal breathing, look at this. So now we have synchronized this sound wave with this tidal breathing of the patient. So patient is just breathing, is not making any forceful maneuvers. Okay. So this is a very, very important thing. So what these machines will do, they superimpose the sound waves on a normal tidal breathing. This is the mechanics or physics of these two machines. Okay. We will move on. Look at this. What happens? So when you are breathing, this is what is the tidal breathing. Okay. You have this is the expiration, inspiration, this goes on. And you are synchronizing the tidal breathing. These are the sound waves along with the tidal breathing. If you are using a single wave, this is called monofrequency. So that means only one wavelength sound wave is used. If you are using a bag or bulk of impulses, this is what is called impulse. This is a bag of frequencies, sound waves. So that means multiple. And you can also have a pseudo random noise. So when you are using this fixed frequency wavelength sound waves, then it is called FOT. That means a machine is producing fixed wavelength. I will come back to that. What are those wavelengths which are used here? Okay. So next important thing is, when you are using either 5 hertz or 10 hertz or 15, 20 hertz, these are single frequency sound waves. This is what is used in case of FOT. And in case of IOS, you use bags of different sounds. Means a machine will produce even 5 frequency, from 5 frequency even up to 30 hertz, the frequency waves are produced. So this is the very important physiology which is required to know about this. What is about the concept of the sound wave? Why these are used? Look at this. If you see this in radio, we used to have AM and like All India Radio, we used to have a FM radio. What is difference between these two is, in case of All India Radio, they use a very low frequency sound waves. That's why they travel a long distance. To quote an example, the Man Ki Baat program is heard even in the corner of the country from Delhi. Whereas in FM radio, you have a very higher frequency sound waves and they travel a very short distance. So this is the principle which has been used in this equipment. I will show you, and look at this. In FM radio, you are using 100 megahertz, whereas in AM radio, you are using, that is All India Radio, just 1 megahertz. So such a small wavelength or frequencies you are using in All India Radio. So this function or property of the sound waves we are using in case of our equipments. Look at this. If you pass a sound wave which has got a lower frequency, then it will travel till the parenchyma, that means terminal bronchioles and to the alveoli. Whereas if you use a higher frequency, look at this 5, and it's a very important. Okay. So you have, look at this. So you are using a 5 hertz, which will travel all along the large airways, major bronchus, segmental bronchus, and then terminal, and it will reach the periphery. Whereas if you use 20 hertz, that means higher frequency wavelengths, it will travel only the large airways. So this is the reason, and it has been found out scientifically that you can use a much higher frequency sound waves, but the patient will get discomfort. And that is adequate frequency, which can give you the lot of information about respiratory system. So look at this. You will have a large airway, extrathoracic airway, and small airways, and lung periphery. What airway can go all this is small or low frequency waves. And the same properties of the sound wave you see here, as I told you, higher frequency only travel up to 7th generation. In other words, the 20 hertz wavelength sound waves measurements are considered as a large airways. Whereas 5 hertz sound waves, they will travel till the alveoli, and that is what is the lung parenchyma. And when you subtract from this 5 hertz and the 20 hertz, that will give you the small airways parameters. Okay. Look at this. This is what is the difference between FOT and IOS. In FOT, you are using either, and what is available. I hope this machine is available. This is indigenously made, make in India. So this machine has got these 4 wavelength sound waves, and it will produce only these 4 wavelength sound waves, and they synchronized with our tidal breathing. So the parameters we get out of these things. Whereas in case of IOS, it has got 5 hertz and 10 hertz, 15 hertz, 20 hertz, 30. So all wavelength sound waves are produced in a bag or a bulk, and that will be synchronized with our tidal breathing. So this is the most important principle we need to understand, and then we can move on to the further things. Okay. So let's see. This is the difference between FOT and IOS. Very important thing what you need to know is FOT has got a single or very few wavelength gentle impulses. It is indigenously made, it is cheaper, though it provides a very good time resolution, and the time taken is little longer, that is 36 and complete the manual. Whereas IOS, it is calculated impedance at any frequency from 5 to 30. I told you the machines which are provided to our they are requested to give, and they will be giving the information from 5 to 30 hertz. Okay. And the duration is reduced 25 seconds and produces a very, very soothing effect. I told you this indigenously made machine has got a piston vibrator that is producing the sound wave, whereas in IOS, it is the speaker which produces the sound wave. So that is why it is very, very less discomfort to the patient, and the patients will not feel any discomfort and they tolerate very well. Okay, that is the advantage of IOS. So once we know the definitions, the concept behind it, and the sound waves which are used, and the principle of these two machines, let's see what are the terminologies which are used and how they are going to be made use in the interpretations. We all know this. This is what is the complete principle of the equipment. And this equipment gives us a parameter called impedance, resistance, reactance, inertance, capacitance, and compliance. And lastly, elasticity. So for the completion's sake, I will give you a little bit of information about all these terminologies. I know in one go, it is very difficult to, I would say take, but you will understand what it is. So what is this impedance? See, pressure waves are passed into the respiratory system. You all have seen, I have explained you already. And these pressure waves have overcome the resistance offered by the airways and lung parenchyma. So the total thing is impedance. The sum of all forces which oppose the generated impulse is respiratory impedance, and this impedance is usually different at a different level of the respiratory tract. It is different in the mouth, different in the pharynx, different in the larynx. And similarly, you can calculate the pressure difference at mouth and in the alveoli gives you a complete impedance of the airway. The same thing, the pressure difference at mouth and the pressure pleural gives you a total lung impedance. In other words, this impedance is nothing but some sort of resistance exerted for the flow of sound waves. That is what is the summary of this impedance. So what this impedance will have, this impedance also has got airway resistance, reactance of the parenchyma, and this reactance has got inertance and capacitance or elastance. So what is this? I will just give an example and tell you. You just see that this is a straw and balloon. So whenever you are passing a sound wave in this straw, this straw has got air in it as well as some amount of resistance exerted by the lumen of the straw. So this is what is known as resistance. Whereas if you see this balloon, this straw is nothing but your airways, and this balloon is nothing but your parenchyma. It has got air in it and also the rubber wall in this. So this air which is there in the parenchyma, that is nothing but air in the alveoli, gives you inertia of the gas. And this capacitance or elastance is the elastic or compliance of the parenchyma for expansion. So ultimately, this impedance has got two components. I told you this impedance is completely from mouth to the pleura. Okay. And in this, we have two things. One is resistance and reactance. And this reactance also has got inertia and capacitance. So finally, these two are called as reactants. So impedance is nothing but or equal to resistance and reactance. So the resistant is depicted by R and the reactance is depicted by X. So henceforth, we will be using these words very frequently. Z is equal to R plus X. So what is this? If you are calculating Z, that is the impedance. If you are calculating the R, that is the resistance, and X is reactance. So move on to further. So as the same thing I have explained here. So the resistance is nothing but if the airway is inflamed, so the diameter comes down. So what it does is you need a higher pressure to pass through this airway for the same amount of air. So when you want to pass a 1 liter of air per second, this you need more pressure because of decreased lumen or diameter of the airway. So this is what is increased and this is known as resistance. So this resistance in your respiratory tract due to central airways or due to peripheral airways. And always think the narrowed airway because of many causes and a secretion within it will increase the resistance. So you just think this physiology, this principle, and later we will imagine where all in respiratory conditions we will have a narrow airways, increased secretion in the airway, or mucosal edema in the airway, and those things we will interpret later. Okay. So resistance at different parts, you can see it has been found out that vocal cord level up to the vocal cord level and from mouth to the vocal cord level, it almost to the tune of 66%. Means larger resistance is here only. And the large airways will produce about 20%. And the small airways will accumulate about 7%. And the respiratory zone is about just 7%. So this is what has been calculated. It is for your information. And ultimately, I just summarize this. So impedance has got two components, resistance and reactance. And this resistance is by central airways as well as peripheral airways. And reactance I have already told you in detail. Okay. So look at this reactance as I already explained you regarding inertia and the elastic nature of the chest wall. Okay. And these together produces reactance. So reactance is equal to inertance plus capacitance. And you see this is how we will calculate and this is what is required for our inertance. Okay. And this, whenever I told you, airway we will have the resistance and in the parenchyma, you will have this inertance and capacitance and this capacitance is dominated in the alveoli. I told you it is the elastic nature of the alveoli in expanding or going back or recoiling and that is what is producing the capacitance. Okay. So finally, I summarize all these components. Okay. We are familiar with these components And this is what is the concept very important in FOT and IOS. Look at this competence. So especially I told you, airway diseases will give you information in resistance, whereas the parenchymal diseases will give you the compliance and elastance. So if you calculate these, then you will know that what is the possible disease in that particular child. Okay, so very important, and we all have come to this level now. Okay, so this is the final flow chart for you to understand these two terminologies. So we are very much interested in calculating resistance and calculating reactance. I have told you how these are derived from our respiratory tract. Okay. How this is going to be produced in FOT and IOS? Look at these graphs, and these graphs are very important. So if you see this, this is the at certain level, the inertia and the elastic has becomes 0. So if you take and look at this x-axis, here it is mentioned 5 hertz and this is 20 hertz. So these are two frequencies are used. And when you synchronize these frequency waves with your normal tidal breathing, this is what you are going to get. This is the red line. That means this much amount of pressure is required to travel this wavelength. Okay. So it is depicted in centimeter of water liter per second. Okay. It can also be given in kilopascals. So what happens? So this graph, this portion tells you about, as I told you, 5 hertz travel till periphery, whereas 20 hertz will travel only large airways. And I told you the phenomena of radio waves. So same principle is applied here. That's why this 5 hertz reaches the periphery in a normal per child with this much of pressure. And the same amount of pressure, even 20 hertz reaches same. So what will happen? You will get a parallel line like this in a normal child. Okay. So what is this? The R5 tells you about complete airway. I told you because this travels from larger airway and it goes to even parenchyma till the alveoli. So that's why it is a complete airway. Whereas R20 tells you about these central airways. So if you want to calculate small airways or peripheral airway, you subtract this R20 from R5. That is R5 minus R20 is peripheral airways. Okay, that is about resistance. Let's see about reactance. So look at this. So the reactance at 5 is exerted at around -1 centimeter of, and this goes in this fashion. At certain points, it becomes 0, and then it will be a positive pressure. Okay. So this is below, it is negative, and above is positive. And this curve in a normal child, this looks like this. So this is what is known as reactance. So at this point, that is at -1, where it begins with 5, is called X5. I have already told you X5 denotes reactance at 5 hertz of sound wave. And this travels like this, and at 20 hertz, your reactance somewhere here, that is in a positive pressure. Okay. In the bargain, you get this graph, and this graph has got, I told you, this portion is because of elastic nature of the lung. And this portion of your graph is because of inertance of the air column in these respiratory, terminal bronchioles and all those things. So if you see this graph, it has got a lot of information for us. And further to that, you see what is this known as frequency resonance. What is this frequency resonance? A reactance at a certain level, it becomes zero. That means it dissects the baseline from negative pressure to positive pressure. So here afterwards, what comes is the inertance, and below what this triangle shaped area depicts the what is known as area of reactance. That is nothing but this triangle area tells you that that particular child's the elastic nature of the parenchyma. You got it? So this elastic nature of the parenchyma is known as area of reactance. This is depicted by AX. So it is depicted by AX. I have shown you the color. So this is a very important graph wherein this will tell you about 5 hertz and this will tell you about 20 hertz, and this graph usually runs parallel to the baseline. And this is what is your resistance of a normal child. Similarly, in a reactance, it is like, from minus, it goes on and dissect the baseline and it becomes positive. And this area depicts you the elastic nature of that particular child parenchyma. And the area above is very, very important. It will tell you about inertance. So how this physiology we should apply in our diseased conditions, we will tell you later. Okay. And while doing this feature, very important is child has to perform at least 3 maneuver, thereby you will avoid the variability in the each measurements. So that is, in order to do that, you should have a less than 15% in child variation of R5 findings. In adults, it is 10%, but in pediatric covariance, that means from individual episode of reading, there should not be more than this 15%. Similarly, in spirometry, you say that each spirometry variation should not be more than 5%, or 100 ml. More than that is not acceptable to consider. So similarly, variability you can see. So I'll just show you one graph here. In this, you can see here, it is written here, covariant is 7.25. I told you until 15 in pediatric age is normal. Similarly, in the post bronchodilator use, and this is after the bronchodilator use. Okay, we will move on. Now, you understood about the graph. You see these parameters and what they depicts. In every graph you get out of it, you will have this type of, numericals and the alphabets. You make use of them. Z indicates lung impedance. R5 indicates entire respiratory tract resistance. R20 indicates in large airways, and R5 minus R20 indicates resistance in small airways. And X5 indicates small airway obstruction and lung elastance and compliance. So very important information is here. And the AX is area of reactance. I told you the triangular area, that is a small area obstruction and lung parenchyma. And I told you about the resonant frequency wherein it dissects the baseline at 0, that tells you airflow obstruction or lung restriction. So, in respiratory medicine, you have a disease And all those diseases produces one of these properties. Either they produces airway obstruction, large airway obstruction, small airway obstruction, or they will produce obstruction in the parenchyma, lung restrictions, or the loss of elasticity. All these in terms we can extrapolate and interpret what is the possible medical condition in particular child. So sum up what is importance and look at these terminologies, and these terminologies are very important for you to understand. So now we have come to a conclusion wherein we will see the graph and we will use these terminologies and interpret the graph very, very, lucidly. Look at this. Now you have a normal complete airway. This is very well a similar graph I had shown you earlier. And the reactance graph I have shown you. And I have also showed you the frequency resonance and area of reactance. Like, fine. So what this tells us, what are the cutoff value? So don't worry at right now about cutoff values. It is still because this is extrapolated from the adults, and I'm just giving for the sake of completion and leave it. And this is given in centimeter water per liter per second. I have written on the right side 1 centimeter of water is equal to 10.197 kilopascals per liter per second. So these values are individual device specific, and the manufacturer will give you the cutoffs, and you should use them and interpret that particular graph, because already in the market you have nearly 4 or 5 equipments, and they are in, they have their own brochure is for age dependent. Okay, right. So I have given you here one of the our 40, that is Antilia, and that has got these cutoff values for the age respective. It is still in the process. They have not been completely standardized, but they can give you some very good information. And if you particularly have it, all the normogram, just like, we can't remember the centile chart of blood pressure in a, similarly, we can use this normogram and plot it and see where we stand. So ultimately, in your FOT or in case of your IAS, this is how the resistance curve comes. As I said, it's very important. This is the sound wave frequency 5, 10, 15, 20. And when you ask, so this is what is the initial 5 hertz, because this is the one which will travel to down. And if it is very high from the baseline, this is the normal one. So I told you normal one will be like this. And if it is very high, that means smaller or distal airways are obstructed. And as the sound wave frequency increases and it comes down, and this tells you the large airways. So in this curve, if curve comes like this tells you only the distal airway obstruction. If it is only the proximal airway obstruction, because even the obstruction is for both 5 hertz as well as 20 hertz, that's why the graph comes parallel to the baseline. So if graph is like this tells you about the proximal airway obstructive disease. If a graph is like this, it will tell you distal airway obstruction. So I hope you understood about the resistance, and this is the reactance. Similarly, look at this. This is the normal airway child. If a child has got a disease which is affecting the airways, smaller airways, as well as parenchyma, then the graph is going to be much deeper. And the triangular area also going to increase. That means this is what is the point where we have called it as the resonant frequency. And this resonant frequency shift towards the right side of your graph. And this is more towards right side. That means more there is a small airways obstruction and there is a lot of loss of even elasticity or compliance of the parenchyma. Okay, so I told you about the resistance. This is the reactance. What will happen in case of obstruction and even restriction? Okay, so restriction and obstruction, in both the conditions, this reactance curve shifts down as well as shifts towards the right side. Okay, right. So final interpretation is, this is what in case of asthma you see. Look at this. This is what is your normal, but in case of your case, this is what is the curve. Okay. Both here, if it is parallel like this, that means even small airways are involved, even large airways are involved, because both are away from the line. This is the normal. Usually you will get a graph which and gives you this weighted value curve, tells you about abstraction. Okay, and this is a very important. And in reactance also, I told you normally it should have been here and this is gone down. It should have been here, but it is gone down. So that's why you have the area of reactance is very much increased. Right. So now we understood about the graph. I hope you will be able to interpret if I give you the graph. And let's understand some about movement parts. And this is how the IOS machine looks. Here you see that I told you, this is the mouthpiece, which is you can see here. And you have in this mouthpiece, there is a pneumotech. And this has got a transducer. And this is the speaker. And this speaker produces a bags of multiple wavelength sound waves, and it will be conducted through this. And this pneumotech and the transducer recognizes the changes in pressure, and that will be depicted in graph. Okay, and this is what has been shown. Look at this. This is the mouthpiece, and this is the flow, and you will see the filters, air inflow, and loudspeaker. Okay, these are the parts of the IOS. How one should do. This is how the machine looks and how the child is sitting straight. I will show you and explain first to the patient, and you need a good counselor and tell about what it is, because the moment you are asking the child to do, especially when you use the, especially your clip, that is nasal clip, and then child become frightened. So you have to tell him and all explain, let the child be comfortable, ensure tight seal between the mouthpiece and the lips to prevent the air leak. And you should make hold of the hands over the cheek. What happens once the sound waves are produced? If your cheek is free, it will usually fluctuate because of the sound waves, and it will give the artifacts in your waves. And that is the reason the cheek should be held firmly and nose clip and be worn, and ask the patient to perform normal tidal breathing. And very important thing is these equipments will tell you that whether child has got normal breathing or not, what is about. All those things are shown in the graphic manner so that you will come to know whether he has got a normal tidal breathing or not. And simultaneously, even these machines have got indicators that will tell you it is good, fairly good, and not good. And you will have to see for every maneuver in this fashion. So recording should be performed at least 30 to 40 seconds. It is different for individual machines. I've already told you. This period is around 120 to 150 sound impulses are pushed into the lung, and the mean reactance and resistance values are determined for 5 and 20 hertz. And once you determine, after taking the three, it will give you the impression, that is the mean of all these three, and it will be giving the judge score also. And after this, you will have to test. If you want to see the bronchodilator response, then you can give the beta agonist and ask the child to wait for minimum 20 minutes. They also say that 200 micrograms is enough, and you can ask the patient to wait for 20 minutes. So make such 3 attempts. Even after giving 20 minutes later, you have to take 3, and you should be very careful looking at the performance of the child. And sometimes many companies provide you bacterial filters, and that is good. And only thing is, you should be aware that it can give you little variations in the readings of the machine to 0.04. And while taking the tidal breathing, make sure that there won't be any air leak and tongue position is normal. Okay. So when you convince that the child, you can always discard if the child doesn't perform, and you can go back to again, reselect it and make the child to perform. Okay. And reflect the reproducibility and importance measurements. So
excuse me, sir.
Sorry.
Excuse me, sir. Our delegates want those 2 previous graphs to be discussed again, please.
Okay, they want it to be discussed again.
Yeah, those previous graphs.
Okay. Yeah, those are the only 2 graphs which comes. Okay, I'll go back and do that. Right. See, I told you these are the 2 graphs. One will tell you the resistance which is exerted by the respiratory system for your sound waves. Okay. And this graph is depicted, I told you, in the x-axis you have the frequency, y-axis is depicted the amount of resistance. Okay. And for 5 hertz, it is the hertz sound wave which will travel till the periphery. And for example, if the child has got, just imagine child has got asthma. We all know that child has got both small airways as well as large airways, and mainly the small airways are obstructed. So what happens, this 5 hertz will need more pressure, okay, to travel. And that is why this is the axis of pressure, and 5 hertz starts from here. And when it starts 5 hertz, then the 10 hertz will come down, and 15 hertz will be lesser, and 20 hertz will be further lesser, because these higher the frequency, they don't go till the periphery. They travel only smaller distance. They travel only smaller distance. That's why they depict large airways. Okay? Right. So this is what has been, again, I'll explain you. So this is about the reactance, right? Look at this. What this tells you is, when 5 hertz travels in the lung from your segmental bronchioles, it will travel again down. This is a 5 hertz sounds have got a small wavelength, so that they will not be interrupted. They travel till the periphery. And this 5 hertz, when it travels, because of elastic nature of the lung, there will be the reactance of -1 pressure. Okay. And this, as the frequency increases, I told you, the larger frequencies will not go deep into, they will be aborted much earlier. And this is the reason, as the wavelength increases, it won't go deeper. The pressure will become from minus to the positive side. And that is the reason at certain points, the inertance and the elastance becomes equal. And that is the reason this area tells you about the elastic nature of the lung. And after this, as the sound waves frequency increases like this, and this is about the larger airways, here what tells you is the inertia of the air which is there in the large airways. Okay, it is in one go. It is, I feel, little difficult, but you will have to imagine, conceptualize how the respiratory tract is there and how the sound waves travel. Right? Am I clear? Okay, I hope you are with me. I'm much slower. Okay, so that is what is in case of asthma, I have explained to you. So we will tell you once the case scenarios comes, you will be able to understand. Okay, I will told about these parts.
That's COPD graphs.
Okay, you want
Yeah.
the COPD graph. Okay. Look at this, what happens. We all know that what will happen in COPD. The COPD is in case we will have all small airways are obstructed and there is a parenchymal distension happens. That means if you imagine your volume curves, you will have a more residual the inspiratory and expiratory residual volume increases. So that is why the functional residual capacity also increases in COPD. So look at this. This is 5 hertz. And this area is depicting you in resistance. And this graph is depicting you reactance. In your machine, these two graphs come separately, the way I showed you earlier. So only this portion is coming on your left side and this portion is coming on right side. But for convenience sake, what has been done is this axis has got the frequencies and this y-axis has got pressure. I told you from 0 above it is in positive, from 0 below it is in negative pressure. You all know that thoracic, that is pleural pressure, has got negative pressure. So look at here. In COPD, 5 hertz, as I said, travel till down, and here it is because of obstruction, it is increased. This is the normal for this child. Otherwise, it should have been here. But what happens in case of COPD, there will be small airway obstruction, the pressure requires more. From 4, it is requiring almost 8. That means almost double. As the frequency increases, you are coming up, the larger airways are not much affected. And that is why this curve comes down by somewhere around 20, it is somewhere around 5 pressure. So it will tell you that which airways are obstructed. So that is why resistance is exerted by the airway and smaller airways are increased because of obstruction. They need more pressure for 5 hertz sound waves. And similarly, if you see that I have told you about reactance. This is what is the reactance curve normally. But what has happened is this is shifted down. I told you negatively pressure. So when the curve shifts down and the triangle also increases, that means the resonant frequency, the red dot what is there, it is also shifting from right side. So the triangle becomes more. When triangular area is called as area of reactance. And this area of reactance increases, that tells you that the elastic nature of the lung and the obstructed airways in the lung is increased. I hope I'm clear with this. So whenever curve shift downs and the frequency resonance, this point is called frequency resonance. We all have understood, I have already told you this terminology, FRES. And this, it shifts right side, that means it has also both the elastance and the compliance of the lung is increased. So it will tell you area under X5 and the frequency has also increased. So the frequency curve shifts towards the right side. When it shifts down, when it shifts right, tells you that this has got a parenchymal disease, which has got airway obstruction, which has got airway elasticity lost. So that means restrictive lung disease. So you will get the reactance information, both obstructive and restrictive disease. And in resistance, you get only obstructive disease information. We will move on. Okay. So this is how a child has to perform. I have covered this. Okay. I have covered this. Finally, you see, I will tell you, this is how curve comes. This is normal curve. This is baseline. And when child performs 5 hertz, this is how the ratio comes. If a child has got airway obstruction, resistant in different grades, it can be mild like this. And if a child has got very severe obstruction, moderate, it will be like this. And further obstruction, you see here, this is a very severe one. That means at 5 hertz, the pressure from here it is going up. Okay, so all these curves tell you the severity. So left end, whenever there's a curve is higher up, that means the smaller airways or distal airways are obstructed. You come back to the reactance. Look at this. This is the normal reactance. You have, this is a reactance curve. It will not be exactly triangular because you are synchronizing with the your tidal breathing, and this, if shifts down, that means it becomes mild, moderate, and severe reactance increased. Okay, so this is a different in different grades of asthma. So I can give you this a very good example of, you can see the severity of asthma patients where you will have more distal airway obstruction, as well as, and this depicts you the elastic nature of the lungs. Okay, so what is this reversibility? I told you, once you got the first readings, after making 3 attempts, you will get the inference. After that, give the bronchodilator, and after that, again repeat repeatedly 3 attempts, and after that, you will get. If the variation in the reversibility of R5 to the tune of 20 to 25%, that means if it is supposed to be 6 pressure at first reading, and after bronchodilator, if it comes down to 5, it should have been 4, it was 6, come down to 5, then it will be definitely more than 25%. So this is how I will show you one graph wherein you will have similar type of depiction. So what happens to the resonance of frequency resonance, that is also is going to decrease. That means the curve which is almost right, which will shift back to left side after giving nebulization. Okay, and I will show you here. And this is what happens. So okay, so this usually shift towards the left side after giving bronchodilator, and that percentage should be 20% in case of resonant frequency, and reactance area should reduce by 40%. That triangular area which I have explained, and these readings are usually individual device specific. So we should have that normogram with our hand, and then only we can be able to explain. And all these machines which are providing even the severity of resistance, mild, moderate, and severe, and the reactance also mild, moderate, and severe, thereby you can calculate the individual patient's disease, what is the severity. So this is what is very important. And you, at a given point of time, don't remember everything. You have a chart with you. Whenever you perform, just compare it and note down the interpretation, and then you make a conclusion. That is always better. So in the first go, you should be familiar with what physiological principles used in this machine, what are the numericals or alphabets which are used, and what these alphabet tells us. Okay. So if you take this graph with the spirometry, if you see this, I told you, this is the sound waves which are, look at this, this is the sound waves which are in increasing frequency, and this is what happens in normal, in resistance. In reactance, this comes like this. Okay, I told you this tells you about the different types of frequencies, starting with 5 to 20 frequency. So if you take a spirometry, the normal curve is like this, whereas your graphs in IOS or FOT looks like this in a normal child. And in case of distal obstruction, which is every one of us are interested, especially pertaining to our asthma, if you see that resistance curve looks like this, starting from high, because 5 hertz is here, the pressure is more, and this is how it looks. And in reactance, supposed to be dotted line is a normal one, but it is shifts down. More negative pressure is required, and the resonance shift more towards the right side. So the area of reactance increases in case of distal obstruction. So in case of proximal obstruction, what can happen? I told you, whenever there is a proximal obstruction means large airways, and the large airways are only obstructed, even whether it is a small wavelength or large wavelength, the obstruction is in the same. That's why you get a parallel line. Okay, and when you get a proximal obstruction, the parenchyma doesn't involve, your reactance is much smaller compared to this, or almost same. Whereas if you see the spirometry, you will have a very, very small, even it will go little high, and the volume is reduced, the height and peak of the curve is reduced, and there will be concavity also. So this is what happens in small, the large airway obstruction or proximal airway obstruction. And in case of restrictive lung disease, look at this. This is what happens. So the curve is remained same here, whereas your reactance is increased. And this is a clue for you, because the airways are normal, the parenchyma is infection more. That's why you get the area of reactance curve more. Whereas in case of spirometry, your curve shift towards right side and very small volume curve. So this is how you should compare. I know I'm going more deep, but I have tried to make it more simpler. I will tell you that it only comes by experience, and every day you have to keep your mind and heart while looking at the report. Take individual down, then only we interpret. Otherwise, in one go, it is not possible. And this is what information you will get in different type of cases. The same thing I have written in peripheral obstruction, what will happen to R5, R20, R5 and R20, X5 and AX and frequency. So properties of the physiology which we have to remember, and these properties we should make use in case of disease conditions. That is peripheral obstruction, central obstruction, combined airway obstruction, or parenchymal or restrictive lung disease. So similarly, we have seen in spirometry, these are the parameters which are going to be altered. Okay. So this is what you need to remember. And for a thumb rule, remember in all these airway obstructive and restrictive lung disease, X5 is more negative. So X5 shifts down as well as the triangle area becomes more, that is AX, area of restriction, area of reactance, as well as frequency shift to right side. So these all areas are increased.
Excuse me, sir. Sir, excuse me,
Yeah.
sir. So can we just go back to that restrictive lung disease graph, FOT graph?
Okay. Yeah.
Yeah.
See here.
Please explain.
Look at this.
Delegate one.
Yeah. The restrictive lung disease, your airways are not altered. That's why even 5 hertz travels normally. The baseline is here. That's why it is overlapping and 20 hertz. So the graph falls on the normogram and you don't see anything. Whereas in restrictive lung disease, what is mainly affected is the parenchyma. And in the parenchyma, what has happened is there will be an obstruction as well as loss of elasticity of the parenchyma. That's why your area of reactance is increased and the resonance should have been here, it's shifting towards the right side. So the triangle is increased. And I told you, even in obstruction, the area obstruction triangle is increased. Even in restriction, triangle is increased. So this property we should make use in case of diseases of the pulmonology. So this is what is the graph competitiveness. I hope I'm clear. Okay. Now we understood all this. I will, Modi sir, how much time? Another 10 minutes I have? Can I have 10 minutes, sir?
Please.
Yeah. So I will show you some of the cases wherein how this either FOT or IOS has been made use in a clinical practice and how we have interpreted and what best it can help you. This case, 13-year-old child, I'll go a little faster and see that whenever you have a questions, we will discuss it later because time is too much now. See, for 3 months and every time this child was given antibiotics, cough syrups, nebulization, and child is getting up in the night, coughing continuously, but no fever was there. And father was a known case of asthma, and he was on ICS. On examinations, only you see bilateral extensive bronchi, and rest all systems are normal. This is the child. And this child, and X-ray I saw it, you all will appreciate, but never been made an attempt. Only this child was given medicine and back-to-back antibiotics and cough syrups. And after examining what I did an FOT IOS on this child. This is my clinic IOS. See the same graphs I have shown you. This is the resistance graph. This is the reactance graph. See here, this is the 5 hertz. This is 30 hertz because this machine is producing 30 hertz. In FOT, you take only 20 hertz. So in 5 hertz, the baseline is here only. Okay. And if you see that the graph starts above the baseline, and what is this color depicted graph? This is the abnormal zone. Means if your graph starts here, that means the child has got abnormality. So in 5 hertz, the child supposed to be graph would have been here, but it is very high. And how much high? It is to the tune of 171%. Okay. And as the sound wave resonance increases, the graph starts falling and it becomes almost normal by 20 hertz. That means large airways are not involved, only the distal airways are involved here. And you come back to here, this is what is the reactance curve. So the first line is this is the normogram for this particular child. It should have been here, and the area of reactance should have been this small triangle. But look at this is much shifted down. That means negatively pressure increased, and this is going on up to here. So the frequency resonance should have been here, it is shifted here. So it is more towards right side. When this shifts more towards right side, the area of reactance is increased so much. How much it is increased? You come back and see here, area frequency, it is almost 149%. So resistance is increased 1%, reactance is increased 149%. Yes. So this gives me a clue that this will be airway obstruction, as well as the small airways are obstructed with this graph. Then what I did, I gave a nebulization to this child and see how much percentage is reversible. Look at this, if you could able to see, I'm sorry, I'll not be able to see this much. I will show you in writing. I have focused it more. Look at this 171, it has come down to 120. That means the graph which is here shifted down. You can see there are three lines. The line below is the normal. The line in between is the after nebulization. So it is reduced from 171 to 120. The change is almost minus 30. I have given you the normogram. Any child who has got R5 hertz, more than 20 to 25% is considered as positive reversibility. The way you do it in spirometry, wherein you will see that more than 12% reversed or more than 200 ml reverse, that means it is positive. Similarly, here more than minus 20 is a positive reversibility. So this particular child has reversed, and that is why look at the resistance is more than 140. I told you this machine has got anything more than 140 is airway obstruction, and reactance is more than 0.15 is increased, and the reversibility also changed. So what I will tell you, this, if you make it meticulous interpretation, it gives you a lot of information, especially the smaller airways and the parenchyma. And this is how I diagnosed this case as asthma, and we started a therapy. Similarly, another is disease and titrating my therapy. This child initially came and diagnosed. Look at this. This is a classical FOT. And I told you, this is the 5 hertz, 6 hertz, 8 hertz until 20 hertz. And beginning the curve started here. So this has come down like this. So this much of increased pressure, this is the green zone is normal zone. It should have been normal for this child, but rather than 4 centimeter of water, this is requiring 8 centimeter. And look at the area of reactance. This should be a normal area of reactance, but this child area of reactance has shifted down so much. And this is why I diagnosed this case as a, asthmatic child. You can see here, the information is given by interpretation. Smaller airway obstruction. And what is the percentage? 120%. And look at the elasticity, 584%. The elasticity. So this information is collected and treatment was started on this child as per the GINA guidelines. And this child was started on step 3 therapy. And after this, and child continued and came after 6 months for follow-up without any flare-up in between. Look at this. And the child, the same child, you see the same Vihan, and that I told you. And this graph was done in the month of, you can see here when test dates, it is in the month of April. 12th April it was done, and I have done the same child in the month of 19/9, that is month of September. And look at the amount of improvement in the lung functions in this particular child. Yes, again, I made it further 25% reduction in ICS. And look at this child. Later, this is on 29/8/23. That was 22, and this is 28. Almost in nearly about 10 months later, this child's lung functions has come back to normal. Okay, so this child on OD dose, and probably this child will be shifted to the intermittent or step 2 therapy according to GINA guideline. This is how the IOS can be made use in your titrating the drugs, monitoring the disease. You can also see that how your child is responding to therapy. And this is what is very important. This another case is, look at this child. This is 17-year-old, and look at her BMI is 35. And this child was not involving any activity. Parents were fed up, and she was continuously putting on weight, and nobody bothered. And she herself withstand from all the activities. And this is the girl. Look at her size. And what happened is, even if you BMI will tell you that severe obesity. And I did a IOS on this girl. Look at the parameters. So R5 hertz is 150%. And if you take the AX is, look at this, it is 135, almost 135% of resonant frequency. And this is the Z score. Usually all these parameters falls on the center green zone, and they are shifting towards the right side. And that tells you that you see here graph. Okay, this is the resistance graph, this is the reactance graph. And this is how I diagnose and take the individual parameters. Resistance is this much, reactance is this much, and finally I diagnose this child obesity with asthma. And never has been tested and never has been treated for asthma. And this child slowly started responding, and all measures with the even airway measures. So now child has got diet and all the aerobic exercise. This child is improving a lot, and she is involving in all routine activities. And last case, I would tell you this 13-year-old child. And every time child goes with a cough, hurried breathing, everybody treated it as nebulization, nebulization, nebulization. But what made me, I did a IOS on this child. Look at this. I gave the information. Yes, there is a definitely small airways are involved. And if you see this reactance, definitely the reactance falls in the, and the area of reactance is huge. And this is what you can see in the graph. I will show you the R5 hertz is 190%, and your frequency is 168%. But what made me, so look at this. I took an X-ray, this X-ray, and if you meticulous in examination, definitely these X-rays will give you a lot of information. And after this, we did a CT, and this child had already parenchymal disease, developed some amount of bronchiectasis, and bilateral extensive. And we did a clinical exome. It turned out to be primary ciliary disc. So what I would suggest you is, this is a lot of information is hidden in these parameters. If you have a right time decision, take a good history, good clinical exam. This is another child. Last case, I think, will tell you very important information. Only child used to vomit and cough. Parents were fed up. Every time everybody has treated him for GERD. But there were no other history, no history of exertion, noisy breathing, or breathlessness. But when I subjected him, even routine investigations were within normal limit, and this X-ray was with the child. And this X-ray, if you look at it meticulously, only what you need to observe here is, look at both the dome of diaphragm, they are at equal level. And this is a very important information clue I got it. I subjected him for IOS. And for my surprise, you look at this IOS, very important here. So this is the baseline, straight line, what is there. And this is the pre-nebulization. And 5 hertz, it is very high. And as it goes to 20 hertz, it comes normal. But once I gave them, it became becomes normal, the change was more than 33%. So what it tells you that this particular child has got asthma, and this child has been started and child becomes all right. And similarly, another case of 6-year-old, this child was only roaming around with a cough, 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 and failed to identify, subjected for all battery of investigation. And it has been very well worked up in a premier institute. But what has failed was they didn't do, this X-ray was with the child. This X-ray looks normal, and they have also interpreted normal. But with the meticulous history and looking at the cough, I suspected different. When I did an PFT, this shows a very small airway. You look at here, spirometry within normal limit, okay? But little early small airway obstruction is seen. But what happens? This is the PFT which a child did with a forceful maneuver. But when I thought this is not an ideal equipment for this child, when I did, FOT on him, everything came normal. So I perfectly ruled out airway diseases in this child and parenchymal diseases in this child. Look at this, both resonance and reactance, both resistance and reactance are within normal limit, and it gave me a clue. I did a scopy on this child, collected the ball, and this is a very surprising for me. So we isolated organism, and this child was labeled as protracted bacterial bronchitis, just 14 days of coamoxiclav, no nebulization, nothing required, child cured. Okay, so this is the family of a doctor, and they were very happy. So these are some of the areas wherein you can apply these two equipments, measure the lung functions, interpret properly. It can give you a lot of informations. Finally, I can conclude saying that oscillometry has emerged as a transformative force in modern pulmonary medicine. It is non-invasive, patient-friendly. You can make a comprehensive assessment of lung functions, early disease detection, personalize the treatment. It can make improvement in the patient care. While standardization, I told, still a lot more work need to be done because this is new to the field. Very few centers are using, and India is a vast country. We have a lot of different races, species, so we need to apply accordingly. And education challenges still persist because I hope many of you may be blaming that what all these words and parameters. But I'll assure you, once you start using, you will start enjoying about these parameters. So the oscillometry is a percent, but it will have a potential impact on your practice and your patient care. And definitely in near future, it is respiratory medicine is undeniable potential impact by the IOS and FOT. Thank you very much for your patient hearing, and I'll be happy to have any questions.
Yes, sir. Thank you so much for making this futuristic topic in pediatric respirology simple and lucid one. Thanks for your extensive and very enriched talk. We have few questions in the chat box we'll take up, and after that also. So over to you, Dr. Rasmi Kapoor, ma'am, for your views, your wisdom and expertise.
Thank you, Dr. Kalapanva. This was a fantastic talk. Since the future of pulmonary function test holds in FOT or IOS only, because it is easy to perform. We even a 4-year-old child can easily perform when you're suspecting asthma or any lung disease. And Dr. Kalapanavar has shown so many examples how useful it it is in the day-to-day practice. I think this lecture was wonderful. Only thing that we have to be wary about is that there are no standard values for Indian children. You know, these FOT and spirometry, that is airway oscillometry, basically depends on the height of a person. So for Indian children, we don't have a standard. We have standard for many other countries, but for Indian children, we do not have. But we are in a process of developing the standardized cutoff for the Indian children also. And right now, people are using this to, monitor the progress of asthma, to monitor and to step down, as Dr. Kalapanavar has already told you. And we should always remember the cutoff we are taking this value and extrapolating it from the adult values only. At R5 more than 20%, R20 more than 18 to 20%, R5 minus R20 around 25 to 40% cutoff, X5 around 25%, FRES around 20%, and cutoff value for bronchodilator response for AX is around 40%. We have extrapolated from the adult values because we use this for adult. Thanks a lot, Dr. Kalapanavar, for making this a difficult topic so easy. Sounds so easy.
Ma'am, should we take up some questions from the chat box?
Yeah. Sure.
Yeah. Dr. Allen has asked, sir, now Antilla uses primary number frequencies. So are the cutoffs same for 5 to 20 versus 5 to 19?
Yes, they are. They are the same, because they started using this prime numbers because, 5, 15, 20, it was giving a lot of resonance. So they instead started using prime numbers where there is no multiplication of the impulses. Dr. Kalapanavar, do you have any other answer to this question?
No, I had shown them actually the age-wise also. And the reason behind this, I'll just show you that if you want, I think that is a very good graph wherein we have made that, this is the parameters, but it will not holds good always, as Madam said, even I am also involved in that study, but it is taking a lot of time and less number of centers are using. And that is why we'll not be able to produce all those parameters, in a, I just, sorry.
So what the question was that because Antilia is using 19 frequency instead of R20. So that is what the question was. So the cutoff value would be same for both, the R19 and 20 both.
Yeah, that's why I'm telling you, whatever the individual device gives their wavelength, that they will give also the cutoff value for that particular. That's the reason I told you every manufacturer provides you the cutoff value for that particular device and that particular strength, that is the sound waves.
Thank you, sir. Sir, is there any limitation of iOS?
See, I will tell you that there are a few questions because see what happens. One is iOS. You can use it from the newborn also. Only thing is interface is changed. So from usually I have done in a 2.5-year-old as less as that, but not more than that. But also you can use, but interface between the mouthpiece and the child is different here, and that only the research institutes are using. That is advantage. But the limitations are few questions need to be answered. One is you don't have a parameters for your population. Number one. So if you don't have a cutoff values, it's very difficult to see meters. If it is done, then that is the reason I'm telling you the manual itself can produce a lot of variations in the parameters and you will have a very tough time to interpret them. Okay, I will tell you cutoff points. Just to give an example, limitation in this is If you want to diagnose a case of asthma, wherein your cutoff value is for what about 3.9? Yes, because 3.9 is also variation. So you don't have that exactly the parameters. 3.9, when a child has got classical clinical feature, it will be used as a supportive, parameters. That's all. It is an add-on to your, armamentarium for diagnosis. Otherwise, you will not have a correct this thing. And few things are there. If a child is breathing tidal breathing, you can produce variations. So some of them, as holding the tongue tight and producing the small tidal volume, and the child is not putting completely relaxing, and those things, and the child, if you measure those things, even your parameters varies. Okay, and otherwise, this is very good device and very less limitations. And if you do it meticulously, it will give you very good information.
Thank you, sir.
The cost is more. Cost is more because each equipment's ranging between 14 lakhs to 20 lakhs IOS, whereas FOT is between 2.5 to 5 lakhs. But what I would suggest you is this IOS, the sound waves which are produced are very smooth. It is completely without noise, and child tolerates well compared to FOT. So FOT makes a lot of noise. The sound waves are very harsh, and also the child tolerance is less. And iOS has got a wonderful, acceptance. I probably, in my center, we do maybe around, I would say, 150 to 200 per month. So I have not seen refusing unless child is frightened to do. Otherwise, it's very, very smooth equipment, and we can easily interpret.
Thank you, sir. So another question from Alan. How the graph of small airway disease obstruction like asthma, obviously it is high R5 and almost normal R20. So how
Yes.
does it differ from a graph of COPD?
No, that's what I'm telling you. You should not look at only the graph. Graph will tell you what is happening. You see the disease, what is producing in the child. See, even in COPD, what happens is your R5 is high. Okay. The presentation of the child, clinical features, signs and symptoms, your investigations, all those things, you see that you cannot straight away say that only the COPD. The presentation will tell you, and it will not be reversible. So you can see those things, and that is what is the similar. See, similar pattern of graph you get, and that is what is there in this child also. I've got a graph which I had shown you between these two. Look at this. See here, the area which is the, I told you, this area will be same for both obstructive and restrictive disease. And you correlate with along with this. So highly increased R5, highly decreased X5, below the cutoff indicates COPD. That is what I'm telling you. Highly is very important pattern. Okay? And look at this, only the small airway and the large airways are almost normal.
And sir, we have to also correlate it with the onset, history, progression, variability, and of course the reversibility.
That's why, sir, the one important take-home message I want to give my delegates is, look, this is, you should know why you are doing PFT. What you want to out of this PFT, so that unless that is not there in your mind, you will not be able to, pick up the findings on this.
So a small percentage of patients show paradoxical worsening of resistance and reactance after a bronchodilator. What is the possible reason and how to interpret it?
Yeah, that is very rarely easy. If a patient who has been excess use of, beta agonist, and who is using more than 2 semester per week, and who is long time and very irregular, and who is not taking, compliance is poor, such children will have a definitely the increased threshold for these bronchodilators, and they can have same thing. Sometimes it will produce reverse, and your curve may go up.
So improvement in how
Very
many
few
of,
percent.
okay, sir. So improvement in
Sir?
how many of the parameters should be considered to label it as a good bronchodilator response?
No, that is what. See, if one parameter is improved, simultaneously there is a possibility of other parameters. There can be variation. That's why the even percentage is also different from individual patient. I mean, individual parameter. So even one parameter is there, because you remember in asthma, all patients will not have the derangement of lung functions. You should remember that a child can have normal PFT also with all clinical features of asthma. So even one parameter is also deranged, and which has got a positive bronchodilator test, then you should consider it as positive only.
So how many months the duration of a repeat IOS? So
See,
after what
ideally,
time?
that's what I'm telling you. It should also depends upon baseline your parameters, and you should know that what for you are doing a next follow, whether your child is responding, not responding, and is free of symptoms, or you want to see that how effective it has made in the pulmonary functions. So all those clinical indications tells you that ideally one should not repeat less than 3 months. That is basic, number one. Number two, if child is completely asymptomatic, not had any exaggeration of symptoms, and he is showing improvement, you want to cut down, and it has been taught, basic is minimum 3 months. So you do it after 3 months. So in my child, what I had shown you, first test was repeated after 6 months, and the second was almost after 10 months of the second. So by then the child parameters have become almost normalized. Okay. So then what I did was I reduced every time almost 25% of the ICS, and finally I switched over only on ICS as and when you use the child. So this child was put on your MART therapy.
So Rasmi ma'am, your views, ma'am?
I totally agree with this. You see, it is an expensive thing. Also, it costs money. So I generally ask them to repeat after 6 to 9 months. I don't repeat every 3 months. Maybe sometimes it happens that I may have to repeat it after, say, 9 to 12 months. If the compliance is good, I know the child will come. Then I ask them straight away that we are just stepping down based on the control also. So I generally do it in the interval of 9 months, not 3 months. And I use FOT machine TremoFlow, and which is extremely, very, very easy to use. It is portable, and I have done it in children as young as 4 years old, and they do it very beautifully. So it all, as Dr. Kalpana also was saying, it depends, and it on how and which machine you have an expertise in. They have expertise in iOS, so the more you interpret, the more you see, the more wiser you become. So it is just that you must have the equipment to sort of interpret the results. So it's FOT, the TremoFlow machine, and other Antilia and all. The FOT machines are a little cheaper. So I think that would be the future, because iOS still costs around 16 lakhs to 20 lakhs. So it's not affordable by many people. So I still think that Antilia and TremoFlow would be in the range of where people can afford it.
Thank you, ma'am. Actually, we are coming to the end of this session, and almost all the questions have been taken up. So we are into the fifth batch of advanced asthma course, and almost more than 500 delegates pediatricians, they have been through this course. Almost all have started doing spirometry, and many have started doing FOT. So what I gather is it is only a mental block to some extent of some inertia of thought only before we start doing FOT. And since last batch, Advanced Asthma Course 4, many have started doing FOT also. And the messages they have been pouring for the wonderful session that Kalapanawar sir has taken up. And we will have a repeat in the PCS also, and including the hands-on. So
Thank you very
we'll
much.
have a many discussion over that also. Thank you so much. And thank you, Kalapanava sir, Rasmi ma'am, for giving us so much of time. You both have kept all of us awake. Thank you. Thank you so much.
Thank you very
Good
much.
night.
Thank you. Good night.
Good night.
Thank you, madam.